I am Dr. Mrs. Ramesh Sarin, the senior most surgical oncologist specializing in breast cancer and breast oncoplastic surgery at the Indraprastha Apollo Hospital, New Delhi. I've done my training in cancer at the Memorial Sloan Kettering Cancer Center, New York. When I came back to India, I was disturbed and distressed at the educated patients coming to us in their advanced stages of breast cancer, and hence started an NGO called Forum for Breast Cancer Protection to help in creating breast cancer awareness and in counseling the patients affected with this disease. This virtual meeting of GAPIO today during COVID-19 pandemic has involved more efforts and more work for the organizers. Thanks to Dr. Anupam Sibal and Dr. Anil Tandon for their untiring efforts to record the recordings of more than 180 faculty members, which is a Herculean task. But I'm happy to see the results, the final results, the final outcome, which is akin to the best in the world. No scientific meeting of this magnitude can be held without discussing cancer, which has the highest mortality after cardiac disease in the health lifestyle changes diseases. We have 3 sessions covering the latest in radiation oncology, in surgical oncology, and in medical oncology. I'm extremely grateful to Dr. Jalali, who heads the first proton center at Chennai, India. I'm also extremely grateful to Dr. Jatin P. Shah, the only Indian who holds the chair of Elliot Strong at the Memorial Sloan Kettering Cancer Center, and he has headed as the chairman of head and neck at the same center for close to 23 years. No head and neck cancer surgery conference can be complete without the presence of Dr. Jatin P. Shah, and we are extremely grateful that he has come and spoken to us. I welcome my alma mater, All India Institute of Medical Sciences, trained medical oncologist in charge at the Dana-Farber Institute, Dr. Shiladitya Sen Gupta. He has the distinction of being associate professor at the Brigham and Women Hospital, at the Harvard Medical Center, at the Massachusetts Institute of Technology. I welcome the 3 illustrious GAPIO members, Dr. Anju Agarwal from Australia, Dr. Lokesh Idara from the USA, and Dr. Jayesh Lele from India for having spared their time in their busy practices to chair the session. Thanks to the attendees, you do encourage us to do more than our best. Please do write down your questions, even if naive, in the chat box with your name and ID. And I promise you will get a reply from the organizers and from the conference personnel in less than a week's time. It now gives me great pleasure to introduce our first chairperson, Dr. Anju Agarwal, who is currently the chairperson and Director of Regional Australian Doctors Network. She is also the past President and Vice President of Australian Medical Graduates Association. In Gapio, she is the co-member of Gapio Women's Forum. Over to you, Dr. Anju Agarwal, for introducing our first speaker. Thank you.
Thank you, Dr. Ramesh Shireen, for the kind introduction, and thank you, Gapio, for giving me opportunity to be the chairperson of the session. Our next speaker is Dr. Rakesh Jalali. Dr. Jalali is the medical director of Apollo Proton Cancer Center in Chennai, South Asia, and Middle East's first and only operational proton therapy facility. Dr. Jalali has been pivotal in initiating proton therapy in region along with unique site-specific cancer management team-based approach. Dr. Jalali is widely recognized globally for his innovative work in high precision radiotherapy and is also known for promoting equitable cancer care for patient populations from diverse backgrounds. Now I request Dr. Rakesh Jalali to give his talk. Thank you.
Hello, thank you very much for your kind introduction. I'd like to thank Dr. Ramesh Sarin, Dr. Anju Agarwal, and the GAPYO, in particular, Dr. Sibyl, Dr. Tandon, for giving this opportunity for this very nice session. And I'm going to talk a little bit about proton therapy. Now, cancer survivors and cancer survivorship is becoming an increasing issue as the number of cancers are increasing over in the globe, but so are the cancer survivors. And some of the earliest data was from the childhood cancer survivor study, where we realized that although many of these cancer patients were surviving for many, many years, but they did have some medical issue, either related to their cancer or more disconcertingly, was also associated with their treatment. And that has been also borne in other cancers, for example, cardiovascular disease, in left sided breast cancer, Hodgkin's disease. There has been an increasing focus on organ preservation, functional outcomes like chewing, swallowing, speech, gait, activities of daily living, and etc. etc. Now, how do we overcome some of these issues? Are by enhanced surgical skill. We now increasingly depend on personalized approach, looking at molecular signature driven therapies, both in targeted systemic chemotherapy and immuno-oncology, high precision radiation, in particular protons, which I'm going to talk about, and eventually in our treatment for or in our taking care of cancer patients, we have to achieve or try to strive to achieve this balance between long-term survival and cure vis-a-vis high quality survivorship. Radiation therapy is indicated and is an integral component of cancer care in about 50 to 60 to 70% of the radiation, either alone or in conjunction with other known forms of therapy. And over a period of time, right from 40s and 50s, there has been a gradual evolution, both in the conventional radiation, which is based on X-rays or photons, and also nowadays we have the charged particles or proton. The protons per se, the concept was many years ago, 1946, Robert Wilson. And what was immediately thought of that time as compared to conventional X-rays, which are neutral and have the possession of electromagnetic properties, protons are a charged particle and they have a lower entrance dose and they deposit their ionizing radiation at some depth. But what happens is at a finite depth, they deposit all their energy at one place, and that is called a Bragg peak. And what is remarkable is that after that, there is literally no dose whatsoever. And if you can put these Bragg peaks around the tumor, there's a tremendous amount of dose differential between the edge of the tumor, where you need the radiation dose, and then there is practically no dose to the surrounding structures. Initially, there needed a lot of hardware. It was very complex. It was restricted an investment. It was restricted to only few centers in the world, from Berkeley to Uppsala and some Japanese center. And the technology that was used was passive scattering and was very, very cumbersome. The revolution, or in a way, how it has evolved over a period of time, particularly in the last 10, 12 years, is what is called a modern proton beam therapy, which instead of scatter technology uses what is called a pencil beam technology. And now we have larger energy also. We have sophisticated treatment planning algorithms like a Monte Carlo. And we also have an image guidance, because we can tell on a daily basis using a cone beam CT, which is otherwise seen in photons also, whether the treatment is delivered at a precise place or not. But most importantly is this technology called pencil beam, where the proton in a very small spot size of ranging from 3 to 12 millimeters can literally what we call spot by spot, line by line, layer by layer, can treat all superficial and deep tumors very nicely, such that you achieve a very nice ultra precise dose painting to the most complex tumor shape. And that has been a major accomplishment of proton therapy in the last 10, 12 years. Because of the pencil beam technology, because we have a robotic couch, we can do lots of things these days. Therefore, the classic indications of pediatric cancer, skull based tumors, prostate cancer is rapidly increasing to involve liver cancer, head and neck, lung, breast, GI, pelvic tumors, prostate, and also whenever we have to irradiate second time. The American Society for Therapeutic Radiation Oncology gives these model policies where they have divided the indications of for the proton therapy as group one, where there we have a very robust evidence, and that includes the ocular tumors, the skull-based tumors, spinal tumors, hepatocellular carcinoma, every single childhood cancer wherever they need radiation. Also, the patients who have genetic syndrome making radiation particularly sensitive to all malignant and benign primary CNS tumors, advanced unresectable head and neck cancers of the paranasal sinuses, retroperitoneal sarcomas, and whenever we have re-radiation. The group 2 indications are where the data is being accumulated, and it is likely in the next few years these also will become as a part of mainstream indications. And that those are early head and neck cancers, thoracic malignancies, lung and mediastinum now becoming number 2 site in the US for proton indication, abdominal malignancies, pelvic malignancies, prostate cancer, and very excitingly about breast cancer as well. What is also unique in proton as compared to photon is its ability to minimize the radiation dose in the medium and low dose wash. Therefore, the risk of second cancers, which is otherwise a major issue in long term cancer survivors, partly because of radiation, is minimized to an extremely low level. And that is a major, major advantage of proton beam therapy as well. In Chennai, based on the vision and foresight of our chairman, Dr. Pratap C. Reddy, we launched the Apollo Proton Cancer Center in attached to an advanced cancer center. It's the first one in South Asia and Middle East, and it's a state-of-the-art proton therapy facility. We have already, in less than 1.5 to 2 years, treated already 250 patients in all sites with CNS, a good number of patients being in pediatric population. The youngest child we have treated is 16 months, and the oldest we have treated 88 years, but also includes head and neck, prostate, GI, thorax, bone and soft tissue, and so on and so forth. We have managed to publish our first proton therapy clinical series recently in the JCO's Global Oncology, and have also published other series in other literature as well, and has been all very encouraging from the outcome point of view. A couple of examples, for example, this girl with an intracranial brain tumor after chemotherapy, it was a germinoma, received what's called image-guided intensity modulated radiotherapy. We could spare a significant amount of normal tissue, including her temporal lobes, hippocampi, which are very important for the cognition point of view. And after the therapy, what we witnessed was she did exceedingly well in her exams of the 12th and was third rank in the entire district. In difficult locations in the brainstem, in the cervicomedullary region, again, proton therapy is indicated, which is associated with excellent outcomes. In head and neck cancers, complex shape, what we have realized is also in older patient population, because the tolerance may be poor, because you have to give chemotherapy also along with them, and there also it is tolerated very, very well. Prostate cancer patients, again, very good. We have also initiated bladder cancer, which is a niche area. For the moving organs in the lung and the mediastinum, esophagus, pancreas, excellent response in unresectable hepatocellular carcinomas, if it is, for example, indicated. Left-sided breast cancer, because you can spare the heart and the mediastinum completely. Also increasing data to combine with immune checkpoint inhibitors to make a cold tumor into hot. So summarizingly, there has been an increasing enthusiasm of modern proton therapy. And this is just to show you the snapshot of how it has significant impact it is already making alone or in conjunction with other known therapies, such that we achieve this balance of long-term cure and a very long-term quality of care or long-term good survivorship. And the percentage of patients likely to be eligible for proton in the next few years is going to be to 20 to 25%. With that, I thank you all for your kind attention.
Wow, Dr. Jalali, for this excellent and easily understandable presentation of a difficult topic, proton radiation therapy. We all know that oncology advances are focusing not only on better survival, but also on better quality of life, organ and aesthetic preservation, and precision oncology. I feel this is the ultimate in radiation oncology, where you have highlighted how the cancer cells are targeted spot by spot, line by line, and cell by cell with a precision in proton radiation therapy. Thank you for making us aware of its absolute and evolving indications. And in fact, I would suggest that more of Indian patients, if they come forward in the evolving indications, level 2 indications for the proton therapy, we will have science and research to advocate if proton therapy is good for them or not. Thank you, Dr. Anju Agarwal, for chairing the session so beautifully. I now invite the next chairperson, Dr. Lokesh Idara from USA. He's the chairperson of API Global Medical Education. He's passionate about medical education in India and has been one of the members to write the position paper for undergraduate medical education in India. He has an in depth knowledge of the challenges faced by us. Over to you, Dr. Idara, to introduce the next speaker for the session. Thank you.
Thank you, Dr. Ramesh Sarin, for your kind introduction. Thank you for GAPIO for giving me this opportunity as a co-chair for this oncology session. It is an honor and privilege to introduce Dr. Jatin Shah. Dr. Jatin Shah holds the Elliott W. Strong Chair in Head and Neck Oncology and chaired the Department of Head and Neck Surgery at the Memorial Sloan Kettering Cancer Center for 23 years. Dr. Shah is a professor of surgery at Cornell Medical College in New York. Dr. Shah has published more than 650 peer-reviewed articles, which have been cited over 57,000 times according to Google Scholar, and has published 14 medical textbooks. Dr. Shah is a world leader in head and neck cancer treatments and currently serves as a CEO of the International Federation of Head and Neck Oncology Societies. Now I request Dr. Jatin Shah to give his presentation.
Good evening. Thank you, Dr. Sarin and Dr. Idara. My task this evening is to share with you, in the short time allotted to me, major breakthroughs in head and neck oncology. As you know, head and neck cancer is a huge problem in India, so much so that over 35% of all cancers in men in India occur in the oral cavity. So this is a big problem. Now, for me to cover all aspects of all breakthroughs in every discipline in the treatment of head and neck cancer is clearly impossible. So I will refrain from making any comments on radiation therapy. You just heard a beautiful recitation on proton treatment, and you will be hearing following me advances in medical oncology. But what I have chosen is to take three snippets of three aspects of surgery and multidisciplinary treatments as examples to share with you the major advances that has shifted the paradigms in the treatment of head and neck cancer. And these three topics are ablative surgery, reconstructive surgery, and multidisciplinary treatments. For example, cancers that occur in the nasal cavity and the paranasal sinuses are now being treated with an entirely different approach than some 20 years ago. Here is a case in point: a patient with an advanced cancer in the nasal cavity seen on this MRI in an axial view showing an extensive tumor filling up the nasal cavity, and in the coronal view, the tumor is going up to the cribriform plate at the base of the skull, and in the sagittal view, in a similar fashion, the tumor extending up to the floor of the anterior cranial fossa. Just 20 years ago, this tumor would have been removed by a standard open craniofacial resection with a incision on the scalp, as you see on the left, and an incision along the side of the nose to gain access to expose the floor of the anterior cranial fossa through craniotomy, and through a lateral rhinotomy, getting access to the lower part of the tumor to remove that in a monoblock fashion, leading to significant aesthetic and intraoperative and postoperative morbidity. Fortunately, advances in endonasal surgery have allowed us now to avoid all the open operative procedures, and this has occurred as a result of advances in intraoperative real-time navigation, advances in instrumentation, advances in three-dimensional imaging, and advanced training in endoscopic surgery. So here is the same patient who would be treated today in this fashion: endoscopic view of the lower border of the tumor through the nasal cavity, providing assessment of the extent of the tumor and the attachment of the tumor to the nasal septum, and beginning of removal of the tumor, uh, uh, albeit in a piecemeal fashion, as you see progressively here, getting up to the cribriform plate, removing the tumor almost in an en bloc fashion, including a segment of the dura exposing the undersurface of the frontal lobes. And the repair of this is performed with a fascia lata graft. All of this done under live navigation to achieve a complete resection. The proof of the pudding is such endoscopic resection provides equivalent survival rates depending on the histology of the tumor. So with proper case selection, we can avoid an open craniofacial resection and achieve equally good oncologic results with a transnasal endoscopic resection without the need for any incisions. Another advance that has taken place in surgery for head and neck cancer is the management of the mandible in oral cancer. In the 1960s, mandible resection, when necessary, was done, and control of cancer was achieved. The only priority in those days was control of cancer. And in addition, we did not have the means to do reconstruction of the mandible. Here is a case in point. This patient is 10 years out after mandibulectomy for oral cancer, and we were glorified that we have cured the patient. But aesthetically and functionally, this man is a disaster. In the 1980s, introduction of the vascularized bone flaps using metatarsal, iliac crest, and eventually fibula revolutionized the reconstruction of the mandible. It became the standard of care for mandible reconstruction. However, in the past 10 years, we have gone even one step further. Not only anatomic reconstruction is made easy and precise with CAD-CAM technology, computerized aided design, and computer aided modeling to restore the contour, provide intraoral lining, achieve aesthetic reconstruction, and also achieve functional reconstruction all in one stage operation. This is the treatment planning CT scan of the patient prior to the surgery who is scheduled to undergo mandible resection for oral cancer with CAD-CAM treatment planning showing the extent of the bone resection and the location of the osteotomies in the fibula-free flap and the location of the dental implants, all to be placed at the same time to achieve dental restoration along with mandible reconstruction. The fibula free flap is raised in the usual fashion, as you see here, and the placement of the implants is shown based on the computer plan. The implants are placed into the fibula free flap before it is transferred to the primary site. And here is the fibula free flap in place, fixated with a reconstruction plate. This is the native mandible. This is the first segment of fibula and the second segment of fibula. And here are the four dental implants. The Here is the patient's post-operative panoramic X-ray, which shows the placement of the implants where the abutments will be placed and the teeth restored in the immediate post-operative period. And here is the same patient some 10 days later with a prefabricated denture anchored onto the implants, achieving dental restoration along with resection of the mandible. We have now gone even one step further, and we are now able to put the abutments and dental implants immediately. So when the patient wakes up with the teeth in the mouth. Here is a patient similar to that, some 3 days post-operative. You can see the sutures are still in place, but he already has a denture placed intraoperatively to restore dentition. So we have made a huge impact on the ability to reconstruct the oral cavity and achieve aesthetic and functional reconstruction. Finally, in the arena of head and neck, a new tumor has entered into the spectrum of cancers we treat, and that is HPV-associated oropharyngeal carcinoma, human papilloma virus-associated cancers, usually occurring in the tonsil and the base of the tongue. This is a new and peculiar disease. It occurs in younger age patients from 40 to 60, more common in non-smokers, usually present with nodal metastasis, but it is highly responsive to any treatment, including radiotherapy, chemotherapy, or surgery, achieving excellent cure rates in excess of 90% of patients. The current focus now there is to minimize sequelae of treatment and, if possible, avoid chemotherapy or reduce the dose of radiation or minimize the utility of three modalities of treatment and preferably treat the patient, if possible, with single modality treatment if the patient presents in early stage. The strategies to de-escalate treatment here is using agents with less adverse effects for concurrent chemoradiotherapy, reducing the dose of radiation, using upfront robotic surgery and modify adjuvant treatment, or use immunotherapy in place of cytotoxic chemotherapy. There are a number of clinical trials currently exploring de-escalation of multimodal treatment for HPV positive oropharynx cancer, and a number of these trials are still recruiting patients. So the final word is not out, but the goal is to minimize sequelae of treatment and achieve best oncologic and functional outcome. So in summary, the current priorities and future directions in the management of head and neck cancer is to improve cure rates, improve recurrence-free survival, achieve the best possible functional and aesthetic restoration, minimize the complications and sequelae of treatment, and we need to emphasize more research in immunotherapy and research in genomics, which are the areas to be explored to achieve the above goals in a more expeditious fashion. Thank you for your attention.
Wow. I wish there was a better word than wow. What an insightful lecture, Dr. Jatin Shah. You have touched only on three cancers in the head and neck region, but you have left an indelible mark in our minds. improvement in cancer cure rates with the best possible functional and aesthetic restoration with good quality of life is the word today. Multidisciplinary approach utilizing not only radiation and medical oncology but engineering, design, and advances in 3D, 4D radiology and reconstructions and pathology. We need to be united in the fight against breast cancer and COVID alike. It's now my pleasure to invite Dr. Jayesh Lele, who is a family physician and Honorary Secretary General of Indian Medical Association. He also held the position of Honorary Secretary of Indian Medical Association Hospital Board of India from 2016 to 2020 and was the president of IMA Maharashtra State in 2015. He has been conferred with Sridhar Sharma Oration Award for the year 2017 in recognition of his services rendered to IMA and IMA National. He also had Individual Service Award in 2015. I now request Dr. Lele to introduce our third speaker. Thank you.
Thank you, Dr. Ramesh Sarin, the moderator for this session, for the kind introduction and inviting me to introduce a very renowned speaker, Dr. Shandilya Sengupta from USA. We are aware of the GAPIO, which is a global association of physicians and the work done in the India as well as abroad. We are very happy that such conferences are organized periodically, and I'm thankful and grateful to them. Thank you, Dr. Sarin, for being a moderator for this session, for my kind introduction, and inviting me to introduce a very renowned speaker, Dr. Shiladitya Sengupta from USA. I'm also thankful and grateful to Global Association of Physicians of Indian Origin for giving me an opportunity to chair the session during this Global Indian Physicians Congress. We are aware that the GAPIO, worldwide global network of physicians, are doing a lot of great work in the education as well as the other variety of work being done. So I'm thankful to them for giving me this opportunity. Dr. Shiladitya Sengupta is a graduated from AIMS New Delhi in 1998 and is currently working as an associate professor of medicine at Harvard in Brigham and Women's Hospital and Dana-Farber Cancer Institute, USA. Dr. Shiladitya is also an associate professor of health sciences and technology of Massachusetts Institute of Technology, USA, where Dr. Shiladitya is focusing on bridging engineering and medicine. Kindly start, Dr. Shiladitya Sengupta. Thank you.
Thank you very much for this opportunity, Dr. Sarin and Dr. Lilly, for this invitation. And I'm delighted to be able to present our work at this conference. In today's talk, I'm going to be talking about some of the research that we are doing at Harvard Medical School, and what are the insights that we're gathering from that, and how does it impact biology. So these are my conflicts. I co-founded and hold equity in these companies. So my research focus, or the focus of my laboratory, could be classified into four broad areas. We're trying to develop platforms which allows us to predict which drug to use for a patient. Another theme for our topic, for our research, is basically to figure out, why treatments fail. Specifically, we're interested in understanding chemotherapy tolerance. We're also looking at very early stages of metastasis, because these are things that we don't really know what is it that governs metastasis. And of course, we are also looking at therapeutic interventions that can activate the immune system. Now, the way we work is that we basically translate what we do into companies. So these are some of the companies that have come out from the lab and have been able to translate products into the clinics. So this is a classical picture that many of you, or movie that many of you might have actually seen. This is basically an immune cell attacking a cancer cell. There is a paradigm shift that is happening in the field of cancer biology or cancer treatment, that you can activate the immune system um, to eradicate cancer. But why is it that the cancer cell can actually even grow to start with when we have such a robust immune system? And that is basically what is driving our understanding of immunotherapy. So what happens is basically that the cancer cells expresses a high level of proteins which are called immune checkpoints. They actually bind to receptors on immune cells, and they basically shut down the immune cell. Okay, so that's why they are called immune checkpoint inhibitors. And the problem that happens is that, so what we are trying to do is basically inhibit some of these targets, which would actually suppress the immune system. I mean, which would actually activate the immune system. Now, what happens with this? The problem that exists is that so this is a classical survival curve that you get with chemotherapy, for example. So most of the people actually kind of would go on to live longer, but at some point of time it stops working. Now with immunotherapy, you actually kind of live uh, slightly longer, but this is not good enough. And so this inhibitor, for example, the survival curve is basically by inhibiting one of the specific pathways. When you combine this with an inhibitor which targets another pathway, you can actually see the survival curve is actually going up. Now, why is it so exciting? Is basically because a large number of these patients will actually live long. This leads to a durable response. But this is not good enough in sense that only 30% of the patients are surviving. And why is it so? So this is something that we have been studying as to why doesn't immunotherapy always work. And one of the focus areas and one of the strengths of my laboratory is to be able to understand biology at the nanoscale. So we use techniques from nanotechnology to understand biology. So what we found is we started looking at applying nanotechnology tools to the interactions between cancer cells and immune cells. What we found is that these cancer cells actually communicate with immune cells in way more types than the immune checkpoints that I just talked about. So what we observed is that cancer cells can actually send out these fine nanotube-like structures. They communicate with, they connect up with immune cells. Here you can actually see a T cell. You can see this tube. It's connecting up with this. Okay, this is another picture. Here is the cancer cell. You can see the immune cells, the T cells. You can see these fine tube-like structures that is connecting up with these two T cells. And if I zoom it out, this is how it looks like. Okay. And here is a bigger zoom-like structure of this specific part. You can actually see this tube has now connected up with the immune cell. Now, this kind of biology was not possible earlier. It's only because we have access to tools that from engineering that allows us to study cell biology at this resolution. So what is the implication of these kind of tubes? Why do the cancer cells produce such tubes? And we started understanding these biology. What we found is that these nanotubes are actually bridges between two cell types. And through these bridges, you can actually see trafficking of organelles that is taking place. So what is the implication of this? What we did was we basically labeled the mitochondria of an immune cell with a yellow dye. And then we added it to cancer cells, which was not labeled. The mitochondria was not labeled at that point of time when we added it. And over 16 hours, what we found is you can actually see some yellow traces here. The mitochondria from the immune cell is now being trafficked through these tubes into the cancer cells. So what the cancer cells are doing is they send out these projections, they connect up with the immune cells, and they suck up the mitochondria. We've replicated the whole thing in primary human tumor cells too. So here is a primary, this is a lymphocyte that was isolated from a patient. We label the mitochondria with a dye, and you can see the green dye has now trafficked to cancer cells. So this is actually happening in primary human tumors too. Now the implications of this is that immune cells are highly metabolically active, for their function. And if you're sucking out the mitochondria, you can actually potentially metabolically inactivate immune cells. So even if you're using an immune checkpoint inhibitor, if the mitochondria is not present, the immune cells will not work. So this is a completely different mechanism by which cancer cells can actually inactivate the immune system. Now, how does it translate into biology? What we are now doing, or into therapeutics, we are now studying what forms these tubes. And there are drugs that we can actually deploy to dissect this, to disconnect this communication. And that can potentially lead to new therapies. Now, that's just, why doesn't immunotherapy work on T cells? But the way I think about it is we need to think about cancer's immune response from a completely different perspective. Let's think from virology perspective. We all know how COVID is activating the immune system. And that's what happens when you get infected by a virus. It's not just the T cells, but you have a whole host of immune cells like the innate immunity or the acquired immunity that kicks in. You have NK cells, you have dendritic cells, you have macrophages. Okay. At the next level of immunity, you have the T cells, you have the B cells. Um, so why not? Why should we just activate only the T cells? T cells. Why not look at the whole spectrum of the immune system against the cancer? And this is what we started thinking about. And this basically, when I started thinking about it, I thought, why not do it in India? This would be a very nice platform because, India has a lot of expertise in immunology. And this can help us build an ecosystem for innovation, okay, and discovering new drugs. So we started a company called Akamara Therapeutics. Earlier, it was known as Invictus Oncology. And we have been able to kind of develop drugs that activate the immune system. This is work done in India, and this was published in Nature Biomedical Engineering 2 years back, and we have been able to file patents. But more than this, we started looking at how do you activate the B cells, and this is the kind of science that we are now doing in a lab in India. So what we have been able to do, this is a drug. So we use high-end computing. So this is quantum mechanical simulations. You can actually see the drugs being formulated here. This drug basically acts via activating a viral response in cancer cells. So you can actually see when we administer this to animals, a tumor-bearing animal, this is within the tumor. There's a significant, about 30-fold increase in interferon levels or type 1 interferons in the tumor. Now, what that means is you have a huge viral response. So the body is, or the B cells are sensing that as a virally infected tissue. What you immediately sense, so this is controlled tumors. You can see day 3 and day 5. The B cells, this is IgKC, which is a biomarker for B cells. It's all in the periphery. Okay. And nothing is there within the very few cells in the core of the tumor. But when we treat it, this is the lower panel is the treatment. You can see the significant increase in B cell penetration or infiltration into the tumors. So what you're doing is you're basically triggering a antiviral response in the cancer. And BLIMP1 is a biomarker for activation of B cells. You can see there's a dose-dependent increase. This Western blot basically shows downstream signals. You can see without the drug versus the treatment, the signals are actually going up. So what that means is basically we have now got a drug that activates the B cells against cancer. What is the implication? We actually tested this in a breast cancer model. You can see 100% of the tumors actually grew in control group, but we had an 85% response in the treated arm. Now, the advantage of B cell response is that once you activate B cells, you have a lifelong memory response. So this is what we did. We actually injected a tumor in a mouse. This was breast cancer. We treated with 2 cycles of the drug. It's called 18-1965. The tumor regressed. We then took spleen and isolated B cells from these animals, transferred it to another animal, which was then challenged with the cancer cells. This is very similar to basically, once you have chicken pox, you will never have chicken pox again. That's the logic. So when you challenge the mouse with the tumor, does the tumor grow? So this is the graph. So you can actually see the blue line, the tumor starts growing. After 8 days, it starts shrinking. And in this case, this was the tumor that I was talking about here. So this means that the immune system has now kicked in and is now eradicating the tumor. Now, are B cells correlated with survival in tumors? So what we looked at is the data from the TCGA data set. This is patient samples. This is the biomarker that I just showed you goes up in tumors in response to our drugs. So you can see low IgKC levels, patients live less. If the tumor has high levels of IgKC, the survival curve basically goes up. So we could potentially we potentially have a therapy that can impact survival. So this drug will enter the clinics in 2021. And this is work that we have actually done in India. So I would summarize by saying that cancer therapy will see a paradigm shift in the coming years. And the way I look at it is basically that India will play a significant role in this shift. And I think Gapio can actually play a significant role in this process by enabling clinical trials and creating an ecosystem where we can actually change how cancer treatment is done. Thank you very much.
A third wow for Dr. Shiladitya Sen Gupta, who is an associate professor at Center for Engineered Therapeutics at the Harvard Medical School, Brigham and Women's Hospital, and Dana-Farber Institute, for making us look at the cancer cell with electron microscopic eyes and at genomic angles. I marvel at your brain and your thoughts, Dr. Sengupta. With people like you, win over cancer is certain in the near future. Thank you so much, Dr. Jayesh Lele, for chairing this session so magnificently. Thank you. Lastly, I would like to say that efforts of people like we heard and other luminaries in the field are helping to improve the life, the quantity of life, and the quality of life of those unfortunate people affected with cancer. Together, we can and we will win over cancer. Unity and multidisciplinary approach with clinical expertise is the word for cancer today. Thank you so much, the organizers, Dr. Anupam Sibbal, the chairperson for the Gap Year this year, Dr. Anil Tandon, their core committee members, the chairpersons, and the speakers for doing justice to this oncology session. Thank you so much, everybody, and I hope we take home the message that cancer is curable. Thank you so much.